While the historical standard was a blind subcephoid approach, the modern standard of care relies heavily on 2D echocardiography. The paradigm has shifted to a point of maximal fluid strategy. The optimal approach is simply the site where the effusion is largest and closest to the transducer, free of intervening structures. When mapping out the procedure, the three primary access windows each carry distinct anatomical advantages and risks. Subcephoid approach. The needle is inserted between the cephoid process and the left costal margin at a 30 to 45 degrees angle directed towards the left shoulder. Advantages: extrapulmonary trajectory, avoids pneumothorax, avoids coronary arteries, comfortable for supine patients. Disadvantages: longest skin to pericardium distance, risk of liver or stomach puncture, technically challenging in obese patients. It is best for emergency blind procedures, large circumferential effusions, patients unable to be positioned upright. Apical approach. The needle is inserted typically in the left 5th, 6th or 7th intercostal space at the point of maximum impulse or maximum fluid on echo directed towards the right shoulder. Advantage: shortest needle trajectory, direct access to the dependent pooling area around the left ventricle. Disadvantage: risk of pneumothorax, risk of injuring the left ventricular apex or left anterior descending coronary artery, higher potential for inducing ventricular arrhythmias. This approach is best for loculated apical effusions, echo-guided procedures. Parasternal approach. The needle is inserted in the left 5th intercostal space. The needle must stay immediately lateral to the sternum to avoid the internal mammary artery, which runs roughly 1 to 2 cm laterally. Advantage: direct and short path to anterior fluid collections. Disadvantage: high risk of internal mammary artery laceration, risk of right ventricular puncture, risk of pneumothorax. This is best for anterior loculated effusions inaccessible via subcephoid or apical windows. Regardless of the approach, the use of agitated saline contrast injected through the needle with concurrent echocardiography is critical before passing the guide wire to confirm you are in the pericardial space and haven't inadvertently entered a cardiac chamber.